Good afternoon. I hope everyone can hear me. We're going to give everybody a couple seconds to join us. We have a great program for you this evening with renowned speakers. And the topic, we kept it nice and simple, carotid. As you know, there's a lot of exciting new data that has arrived. And it feels, at least to me, that the field is getting rejuvenated again. There's a lot of energy, a lot of interest, both from the patients trying to understand the recent data, but also from our primary care doctors, vascular surgeons, interventionalists. And also there's a lot of interest from industry because they feel like there may be an opportunity here to partner with folks like us and try to bring this cutting edge treatment to our patients given the recent data. So with that, I'm going to get started. Just a couple of slides introducing you guys to the team here. First, I want to mention that this is a CME event. The objectives of the event are outlined here. We're going to briefly discuss the CREST-2 data. We'll then discuss patient selection and technical aspect of transfemoral, carotid, cervical, and CEA, and proper patient selection in the era of CREST-2 for those considerations. And I'm going to try to discuss some procedures and hopefully have a good, healthy discussion with the panel related to these objectives. My co-moderator here is Dr. Subhash Banerjee. I think all of you guys know him. And our panelists are also well-renowned. And I think most folks on the Zoom know these folks. Dr. Aronow from Henry Ford, Detroit, Michigan. Thanks, Herb, for being here. Dr. Bradley Grimsley, who is still trying to get on, I think. And Dr. Alpesh Shah from Methodist, Houston, Texas. So thank you. Thank you, Alpesh. So with that, these are our conflict of interest for the speakers and ourselves, for those that are interested. And all of this will also be available online for those that want to review them. As I mentioned, you can get credit for this CME event. I want to give recognition for a non-restricted grant that we have received from Abbott Laboratories, Boston Scientific, Cordis, and Medtronic, to be able to bring this kind of education to you without kind of a conflict and with CME regulations so that you can get a good and a balanced view of the topic. Again, you can get your credit via the link that is attached here. And if at the end, if you don't get this link, please go to the CVI Innovation website and you can get the information there. Oops. It goes without saying that we look forward to seeing all of you at our international meeting. This year is going to be held in Denver, Colorado, August 6th through 8th in 2026. As you know, this is a very special meeting. If you like to have one-on-one with faculty, if you like to learn technical aspect of interventional cardiology, coronary, structural heart, endovascular, if you like to be in a very close and a friendly environment with your colleagues and see some live cases and case-based discussion, this is kind of the meeting for you. Again, please either use the bar scan that is shown here, the QR code, or cvinnovations.org/CVI 2026 to get more detail and for registration. There's a lot of opportunities for fellows, early careers, for bridge grants, to be able to attend this meeting in a way that we can compensate and cover with various grants your travel. We really believe in education in CVI, and that's the purpose of this meeting, education and learning from each other. And all of our webcasts, every webinars we have done, every CVI that we have had, international conference that we have had, all of these are available at cvinnovations.org. So please don't hesitate to download or meet our website and get a review of previous topics that we have covered as part of these webinars and our national meeting that we hold every year. So with that, let's get to the meat of the matter tonight. I'm going to take the privilege here of presenting a couple of slides just to set the stage for us. What did we learn from CREST-2? I'm going to hand it to Dr. Aronow to discuss the technical aspect of transfemoral carotid artery stenting. And we go to Dr. Shah to discuss era of CREST-2, CEA and approach with some cases. And then lastly, we're going to go to Dr. Grimsley to discuss TCAR in the current era. And we have a good discussion. And please send your questions via the chat, and we'll try to address these. Dr. Banerjee is also here. Between the both of us, we'll try to get to the bottom of all these. Okay, so I'm going to stop sharing and get my slides, and I'll promise I go quick. Okay. Hopefully this will work. See. It says here you're sharing me on another desktop. How is that? That's not true. And I just did this and it was working. So I'll try one more time. Give me 1 second.
If not, Mehdi, you know the CREST-2 study. You can summarize it extempore.
Yeah. No, I think I can get it. Give me 1 second here. There you go. Like we said, it's not going to be fun if we don't have these technical challenges. Here we go. As Herb said, we're outside of the cat lab, we are lost, and he's right. Okay, well, the slides are going on their own. So I think what I wanted to do is to set the stage quickly in 5-6 minutes, hopefully. In my mind, when I saw patients for carotid disease before CREST, I kind of asked myself 2 questions. What's the actual risk of a stroke in this patient if I don't do anything, if I just treat them medically? And a lot of times I tied it to the life expectancy. Is the patient going to live 3 years, 4 years, 5 years? Because then I had to balance that risk of a stroke with peri-procedural risk of a stroke and death and MI in those patients, meaning that if I were to offer them revascularization, there would be a risk that the patient has to take. And then if I don't give them that risk, what would be their risk of deferring that risk and not doing the revascularization if they were treated medically? And it's been very interesting because the data that we had until CREST-2 was really reliant on the surgical data from CEA. This is the ACAS and the VACAS and ACST trials, the 3 trials that compare medical therapy to CEA. And what we had learned and what the guideline had told us, and it's a Cochrane review, that the risk of a stroke for asymptomatic carotid disease is about 1% per year. And if you decide to treat the patient, the peri-procedural risk of a stroke or death is about 3%. So when we saw patients, we said, well, there could be a risk of 3% risk of a stroke and death, and then 1% per year cumulative risk of a stroke. And looking at the life expectancy and so on and so forth, we made a decision as to whether treat the patient with revascularization or proceed with medical therapy. What was happening in our field was very interesting because a lot of folks were publishing papers saying that actually the risk of a stroke is not 1%. The risk of a stroke may be 0.3%, 0.4%, that because of medical therapy over the years, as you can see here in the x-axis, over the years, the risk of a stroke was declining, reducing. And because of that, we were being too aggressive. We were calling the risk of a stroke in these patients because of aggressive medical therapy. And the most recent one of these was in 2010, which the authors published the OX-VASC study. And in this study, they were saying that the risk of a stroke is about 0.3, 0.4%, and that we shouldn't be doing revascularization for patients who have asymptomatic carotid disease. Interestingly, a lot of these studies were focusing on 50% stenosis, which we're going to come to in a couple seconds. And when you looked at the studies, it was kind of interesting. For the sake of time, I go quickly through this, but I think this is a good point for the audience to kind of take in, because there was a lot of noise around not treating these patients. But this is the OXVASC study. It's kind of fun going through it. There were 1,153 patients that were evaluated in that study. It turned out that only 177 patients had a stenosis of greater than 50%. So we went from 1,150 to 177. Of those, it turned out only 101 of them were asymptomatic. The other 66 or so were 76 or so were actually symptomatic patients. So only 100 patients had asymptomatic. And then when you looked at the lesions, you see that actually the majority of the lesions were 50 to 69%. So only 1/3 of the patients had 70 to 99% degree stenosis, the kind that we are interested for asymptomatic carotid disease. So many of us were getting on these debates and basically arguing with folks who were saying that medical therapy works for this population based on 33 patients. Based on 33 patients, people were making big claims that medical therapy alone would be sufficient for patients with asymptomatic carotid disease. So that brings us to CREST-2, which to me, I think is one of the most seminal papers in my era, to be honest with you, that has come from NIH to lay the ground of what's happening in this field. As you know, and I'm not going to go into too much detail because I think everyone here is familiar with CREST-2. It's published in New England Journal of Medicine. Most of us have read it and have seen it. But the bottom line is that there were two arms. One arm was stent versus optimal medical therapy, about 1,245 patients in that arm. And the other arm was carotid endarterectomy versus medical therapy, 1,240 patients in that arm. 155 centers, so this was very generalizable, and they had very, very strict criteria because a lot of the previous trials of carotid stenting had been criticized for lack of operator experience. So in CREST-2, they wanted to make sure that they had the right people as part of the trial. The patient selection was patients over the age of 35 years, and they had to have no history of a stroke, TIA, or amaurosis fugax within 6 months. And this was one of the key points, that the stenosis for these asymptomatic patients had to be really severe. So greater than 70%, they required an end diastolic velocity of greater than 100, and they wanted the ratio of greater than 4, or a CTA or MRA that showed greater than 70% lesion. The exclusion, it was obvious stuff. And the medical therapy was in both arms. It wasn't just a medical arm. It was both arms got intensive medical therapy. And as you can see here, the targets were very impressive. Systolic blood pressure of less than 130, LDL of less than 70, and so on and so forth in regards to optimal aggressive medical therapy. This is the medical therapy. You can see that there was no significant difference between the arms, between the medical therapy and the stenting shown on the top. And on the CA arm, similarly, you can see that the LDL, blood pressure, those kind of things were very comparable between the two groups. The primary endpoint of the trial was any stroke or death within 44 days of randomization, or any ipsilateral stroke on the side of the revascularization, whether it was CEA or a stent, up to 4 years. And remember, again, going back to the question that we started with, was that, what is the actual risk of a stroke in the current era, in the era of aggressive medical therapy, even optimal medical therapy, to the intensity of CREST-2? What's the actual risk of a stroke per year? And two, what is the risk of periprocedural death and stroke and MI when you do carotid revascularization? And to me, these are the most important points of CREST-2, if you ask my opinion. And this is the data. I wrote it at the bottom so you don't have to go through the table. The table is at the top just for evidence and for reference. But the bottom line was this. The annual event rate in the medical therapy arm was 1.7%. So even with aggressive, optimal medical therapy of calling patients frequently, providing free medication, frequent consultation, and so on and so forth, the risk of a stroke per year was about 1.7%, and the annual event rate in the CEA arm for medical therapy was 1.3%. So I think that's a very important point, because again, some folks were saying that the risk is 0.3, 0.4, because we have statins, we have aspirin, we have smoking cessation. But the reality is that even in the optimal setting, the risk seems to be between 1.5 to 2% for medical therapy alone if you defer revascularization for patients with significant asymptomatic carotid disease. The second point of this was that, well, what's the risk of periprocedural stroke and death in this population? Meaning that putting a stent, are we causing a lot of events? Remember, we had said previously that it was about 3%. Well, once again, CREST-2 showed that that was not accurate. The actual risk was around 1% for both arms. For the stent arm, the periprocedural risk was about 1%, and for the endarterectomy arm was also around 1%, but it could have been as low as 0.3, 0.4%. So if you had very experienced operators, if you had the right patient selection, you could even bring your risk of a stroke to lower than 1% to around 0.4, 0.5% for this population. And obviously, you know, the data that showed that stenting was superior to medical therapy and endarterectomy in these trials, and at least it was definitely better than medical therapy in that arm. CEA was not able to reach the statistical significance. There was a trend towards benefit, but it was not statistically significant. But again, to me, I think the great points were those two. One, the annual risk of a stroke, and two, what is the actual cost of revascularization from a standpoint of a stroke and death in this population. So anyway, from my perspective, I always have thought of medical therapy being complementary to revascularization, not replacing revascularization. And with those kind of two ideas in mind, let me hand it to my partner here, Dr. Aronow, to talk about transfemoral carotid artery stenting and teach us some techniques and some discussion around patient selection and anatomy in this population. Thank you so much.
Mehdi, thanks. Appreciate that. I'm just going to share my screen here. Can you all see my title slide?
Yes.
Yes.
Excellent. So it is an exciting era, and there's a lot of attention that is returned to carotid artery stenting. When Mehdi and I were fellows in Cleveland in the early 2000s, sorry to give away your age, Mehdi, it was very common to finish fellowship having performed 50 or even 100 of these in a very short period of time. But that's not true anymore. And so I think it's worth returning to the basics. I'm going to take you through a case that I did last week with my superstar fellow, Faraz Sukan, and we'll walk through the technical aspects of transfemoral carotid artery stenting. Just having a hard time getting, there we go. Okay. So here's the case. It's a 49-year-old patient with COPD and ongoing tobacco abuse, hypertension, dyslipidemia, type 2 diabetes, and coronary disease with a left circumflex intervention in October of last year for unstable angina. He was referred to me for management of a severe left internal carotid artery stenosis that was found on screening carotid duplex ultrasound and confirmed by CTA. He had no history of stroke, TIA, or amaurosis. You can see his velocities for his carotid duplex ultrasound there, a peak systolic velocity in the left internal carotid of 329 and the common of 113, which gave him a ratio of 2.9 and end diastolic velocity of 121 centimeters per second. Now, he wouldn't necessarily have been eligible based on those criteria for CREST because he didn't meet all the criteria for inclusion, but by CTA, he did. On CTA, he had a 70 to 80% non-calcific stenosis in his left internal carotid artery stenosis. His arch, as you'll see in a moment, was type 1, and I'll walk through what that means. His labs were unremarkable. Given his asymptomatic severe ICA stenosis, I quoted him a yearly stroke risk of around 2% on medical therapy alone. I offered him revascularization to mitigate his long-term stroke risk. We talked about the risks and benefits and the alternatives of transfemoral carotid artery stenting, of carotid endarterectomy, and of TCAR. And through shared decision-making, he elected to proceed with transfemoral carotid artery stenosis. He was already on DAPT for his coronary disease and recent PCI. I asked him to continue that. He continued his statin and the remainder of his GDMT as well. I had him hold his antihypertensives on the morning of the procedure just because sometimes patients can develop hypotension as a result of ballooning and stenting the carotid sinus. So we started out with an aortic arch, aortogram, and typically we'll get that from about a 30 to a 45-degree LAO projection using a large field of view detector, a DSA. We'll then follow that up with selective oblique and lateral views, ipsilateral oblique and lateral views of both common carotid arteries. As you'll see in a moment, we'll ultimately look at the intracranial vasculature as well. Whenever possible, I'll try to use a relatively straight catheter like a JR4. Some will use a Berenstein. That's shown on the right side of the slide. I know you're all familiar with that catheter, but sometimes the anatomy may be more challenging, either tortuous or there may be some unfolding of the arch, and it may be necessary to use a Simmons or a VTEC catheter. And those shaped catheters require more manipulation at times and certainly have a higher risk of embolization. So really they should be used when less shaped catheters like the JR4 aren't successful in engaging the vessel. So I want to walk through what I meant a moment ago when I said a type 1 arch. When all three great vessels arise from the apex of the arch, we refer to that as type 1. Sometimes those vessels will shift more caudad over time, and so there'll actually be a situation where, for example, the innominate may arise 1, 2, or more common carotid artery diameters inferior to the takeoff of the left subclavian artery. When that innominate arises one common carotid artery diameter below the left subclavian takeoff, we typically refer to that as a type 2, and when it arises 2 or more, a type 3. The implications of that, and you can see cartoons in the upper panel and actual still frames of real angiograms in the lower panels, but the implications of that are as you move from a type 1 to a type 3, if you're coming from a transfemoral approach, it becomes much more difficult to take that turn up into the common carotid arteries without significant catheter manipulation and a risk of prolapse. So when you encounter more hostile arches, your options are forgo carotid artery stenting if you're uncomfortable with that, consider CEA or TCAR, relegate to medical therapy if your patient's not a candidate for CEA or TCAR, or of course proceed with caution. Now, the type 3 arch is not the only anatomic situation in which you should take pause. There are other situations, like as I move from left to right here, the bovine left common carotid artery, which arises often at about a right angle off of the innominate. Again, that can be more challenging to navigate, especially early in your experience. You can have significant internal carotid artery angulation, as shown in the third panel from the left here, where there's an S curve that you might have to navigate with not only a distal embolic protection device, but also your equipment, your balloons and stents. And then you can have significant proximal tortuosity, as shown in the panel to the far right here, that can be challenging to navigate, and often it can create situations where you don't have the support that you need to advance your equipment more distally. If you elect to proceed, again, my caution to you, if you're early in your experience or early in your career, is go with the type 1s. Try to keep things simple. Minimize your catheter manipulation while you're doing so. Change to a new catheter early. Don't spend a lot of time whirly birding your catheter and exposing that patient to an increased risk of stroke. And choose appropriately shaped diagnostic catheters. Remember, the external carotid artery can help you quite a bit, especially as you transition from the diagnostic to the interventional portion of the procedure. You may ultimately end up putting a glide wire and ultimately a stiff wire there over which you can rail your diagnostic catheter and sheath and ultimately intervene. The angiographic views that are real steep, like lateral cross-table views, are very nice at displaying the carotid bifurcation, but not good working views because you can't actually see if your catheters begin to prolapse out into the aorta, a situation that would be very dangerous. If you're going to be performing carotid artery stenting with embolic protection, distal embolic protection, this cartoon here highlights the correct placement. You can see that you want it to be deployed in a straight segment of the vessel. You'd like the tip, the wire tip, to be in the petrous portion of the distal internal carotid artery. When it comes to stenting, it's very common that you would jail the external carotid artery, and this almost always occurs without event. When there are issues as a result, it's typically short-lived jaw claudication, given the fact that this is a very well collateralized bed. It is highly unusual that one would have to try to navigate through a self-expanding stent to rescue an external carotid artery. So on the left cartoon, you can see a stent that extends from the internal back into the common carotid artery. On the right cartoon, you can see a situation where there was isolated internal carotid artery disease and where a stent was placed in the ICA only. So let's start out with the angiograms from this patient that I presented. This is an LAO arch aortogram from, in this case, about 30 degrees. You can see that all three great vessels arise from the apex of the arch. You can see that the right vertebral artery is slightly larger, so that we would say it's dominant. And if you can see my cursor here, there's a stenosis just after the bulb in the left internal carotid artery. Next, we obtained an RAO angiogram to splay the innominate and right common carotid arteries, and ultimately advanced a stiff-angled glide wire into the right common carotid artery, and then advanced the JR4 diagnostic catheter over that. This is selective images. You'll see the actual loop, the cine on the right, and the still image of the carotid, the right on the left panel. Again, there's just minor luminal irregularities. From a straight cross-table lateral, 90 degrees, again, you'll see really just minor luminal irregularities in the right common carotid artery. We then move up and look at our intracranial angiogram, and you can see here there's no substantial intracranial atherosclerosis, there's no vessel cutoff, there's no aneurysms or arteriovenous malformations noted. And you can see that the right internal carotid artery supplies the right middle cerebral artery, the right anterior cerebral artery. And because you can see filling of the left anterior cerebral artery, you know there must be a patent anterior communicating artery, or ACOM. This is a still frame and a loop of the severe stenosis that we saw in the arch aortogram. I think you'd agree with me that that's somewhere on the order of about at least 80% in diameter reduction. Remember, we used the NASA criteria, so we're not comparing it to the carotid bulb, but rather to the carotid artery diameter just beyond that. This is a lateral or cross-table lateral view, 90 degrees of the same. This is the intracranial runoff from the left internal carotid artery, and you can see that it supplies the left middle and left anterior cerebral artery. You don't really see crossover here, and it's likely because we couldn't generate enough pressure head through that tight stenosis when we were injecting contrast to do so. This is the lateral view, and again, no abnormalities seen on these views either, at least no intracranial abnormalities. So most commonly, we'll advance a stiff-angled glide wire, and then over that, advance a JR4 or whichever catheter we were using, diagnostic catheter. It's been a really long time since I've used a guide catheter. They can be handy, the H1 guides, when extra support is needed, but most of the time, a sheath will suffice. And so in this case, we used a 6-French 90-centimeter shuttle sheath. These cartoons highlight the technique. Typically, the diagnostic catheter in the arch is advanced into the vessel of interest. In this case, the cartoons are showing the right common, even though in this case we were intervening on the left common and internal carotid arteries. A stiff-angle glide wire is advanced into the external carotid artery. And then you can see on this slide, the diagnostic catheter is advanced over that glide wire. And then over both, the sheath is advanced until it sits into the common carotid artery. Then the glide wire and the diagnostic catheter are removed. The catheter is de-aired, and we proceed with intervention. Here in the middle panel, you'll see after the embolic protection device was placed, you can get a better sense of that device on the unsubtracted angio on the far right. You can see the opened and fully opposed NAV6 filter in place. You can see the tip of that the wire tip of that filter in the petrous portion of the internal carotid artery. And you can see a 4 millimeter by 20 millimeter balloon inflated for predilation. You can see the radiopaque marker from the sheath sitting here in the common carotid artery as well. I actually didn't, from this case last week, get good images of the stent, so I'll show you representative images in here instead. You can see typically as we start to unsheath the nitinol self-expanding stent, it will flower, and as soon as it gets to about that point, you have the ability to pull it back a millimeter or two. You can't really and shouldn't really advance it, but that's why it is helpful to have the stent a little bit further beyond where you want to deploy it, and then put it in the appropriate place before you fully deploy, which is what you'll see here on the right panel. Post-dilation is something that not all operators will do, and when they do it, they won't necessarily do this in all situations. And again, the reason is that there's embolization, microembolization that occurs during the procedure. You can measure that if you choose to using transcranial Doppler, and it occurs most significantly during stenting and post-dilation. So some operators, in an attempt to minimize that, will skip this step. I inflated a 5 by 20 millimeter balloon to post-dilate the stent once it was in place. Keep in mind the filter is still up. I thought it looked to me like the flow is a little bit sluggish at this point, and so I was concerned that there might still be debris or might be debris in the filter. And in that situation, there's often a stagnant column of blood that has microemboli sitting in it. So I performed manual aspiration thrombectomy and removed about 20 to 40 cc's of blood just to minimize the debris that might be sitting beneath the filter. And then collapse the filter. It's a little bit hard to see, but you can see the filter being pulled back on the right panel there. After removing the filter, we repeat our selective common carotid angiography from multiple projections. You'll see there's really very little significant residual stenosis, and there's normal flow. You'll see that the external carotid artery isn't significantly pinched either. This is a lateral view of the same. Next, we turn our attention to the intracranial runoff, and you can see brisk flow, perhaps even better than pre-stent, of the left internal carotid artery filling the left middle and anterior cerebral arteries. And of course, we see no vessel cutoff, nothing to suggest that there's been embolization as a result. The patient developed some hypotension following stent deployment, which required pressors, and actually remained hospitalized for a second day instead of going home the next day just because of the soft blood pressures. He had no new neurological events. We did hold his antihypertensives at discharge with the plan to restart them as his blood pressures crept up over the coming days. That's what you would normally expect. He continued his DAPT and statin. He was counseled about the importance of smoking cessation, and the plan was for him to undergo carotid duplex ultrasonography again so that we'd have a new baseline during the first week post-discharge. I'll plan to see him back in about a month. So I'll pause here for discussion about the case, or if our moderators prefer, I certainly am happy to wait until later on when we do Q&A.
Herb, fantastic. Thanks for justifying this topic and going over those key steps so in a deliberate fashion, because these techniques are crucial for achieving the results that people achieve in clinical trials because we base them off it. So thank you for doing so. We'll get back to the discussion at the very end. Let me move on. Thank you. Fantastic conversation, fantastic talk. I really enjoyed it. I'm going to invite my dear friend and colleague, Dr. Alpesh Shah. He's a very, very well-known and nationally and internationally recognized for his expertise in interventional cardiology and carotid stenting and carotid interventions. But I've asked him to talk today about the role of CEA in the CREST-2 era. Now, Mehdi has already justified why this era may be defined as CREST-2. And I think this would be a good and a provocative discussion. Herb, if you can unshare your screen, and then we will go on to Dr. Shah. Dr. Shah, I think over to you. Please share your screen. And thank you for being so gracious with your time and presenting today at CVI webinar. You are ready. Perfect.
Is that good?
Yes, that's fantastic.
All right. Thank you, Subhash. Thank you, Mehdi, and fellow. Thanks for inviting me. And right, when you called me about this topic, I had to really gather my energy and strength and get the blessings of my vascular surgeons, Alan Lumsden's extra testing. I'm going to talk about why should I send you patients for endarterectomy, because they haven't heard from me for a long time. But that being said and done, I'm up to the challenge, and it has actually allowed me to learn more from CA perspective. So thank you very much for getting me involved in this topic. I'm going to show you guys a couple of cases. This is an 81-year-old male with right ICS stenosis who's asymptomatic. But look at this. This is a severely calcified stenosis, tortuous calcific artery. What do you do next? Hold on to that thought. We'll come to that in a bit. I'll show you another case, 67-year-old male with left ICS stenosis and recurrent TIA, severely thrombotic with subtotal occlusion, almost like a string sign on the left carotid artery. What do you do next? These are going to be challenging cases that you all have to be aware of. Another case we'll talk a little bit about, a 73-year-old female with right intercarotid artery stenosis and TIA, severely calcified with subtotal occlusions. We are unable to advance filter wire. We had unsuccessful dilation with a 1.5 balloon. What do you do next? So that's where I want to give you guys a little bit of perspective. So we got to start with the CREST-2 trial, one of the most important trials of our time. Very impactful. So it talks about medical management and revascularization for asymptomatic carotid stenosis, as Dr. Shishehbor has already gone through some amazing slides talking about the details. So what I really want to focus on in this particular slide are the outcomes. On the left side, you have 2.8% 4-year event rate in the stent versus 6% event rates in the intensive medical therapy alone, so significantly reduced risk. However, on the endarterectomy trial, there was no significant benefit because it was 3.7% at 4 years versus 5.3% at 4 years. And that basically means that endarterectomy did not show significant reduction in the risk. And that has created so much news saying, oh my God, endarterectomy is not necessarily superior to medical therapy based upon CREST-2. But there are certain nuances. We got to understand why that would happen. So for example, we can see that over this 4-year slide, there is clearly that there is differential between medical therapy and both endarterectomy or stenting. However, after 3 years, there's a little bit of a catch-up which happens in the stenting in the endarterectomy group. And basically, I don't want to question the statistical endpoints, but if this was analyzed at 3 years, maybe the difference would have also equally favored endarterectomy. I think there's a general consensus based upon a lot of historical data. Let's talk a little bit about carotid surgery. It was one of the most common vascular procedures performed to prevent ischemic stroke, with almost 150,000 performed annually worldwide and approximately 45,000 in the United States. The first successful entry was performed by my own very founder, Dr. DeBakey, in 1953 on a 53-year-old male with 2-year history of TIAs. Dr. Denton Cooley, his partner and one of our other founder, performed his CA at Methodist Hospital in 1956 using a polyvinyl shunting in a 71-year-old male with 4-month history of hearing fluid swishing in his ears. Dr. Imparato described using a carotid patch to prevent carotid restenosis, which was a huge breakthrough. And Dr. Guy in the 1970s started utilizing shunts during CA to significantly improve patient safety by minimizing the risk of stroke associated with temporary blood flow interruption. So these are some of the hallmark advances in carotid endarterectomy. The NASCET trial, which is a must-know trial, which was a North American symptomatic carotid endarterectomy trial. Remember, the key word is symptomatic. It did show that CEA reduced the risk of stroke by 65% compared to medical therapy alone in patients with high-grade stenosis, especially if it was more than 70%. But even for moderate stenosis in symptomatic patients, there was still a significant benefit. However, the caveat is maximum medical therapy. This is the 70s and 80s. 80s and 90s, medical therapy did not include standard statins. Yes, it indeed include aspirin. Yes, it included smoking cessation, diet changes. So keep that in mind when you try to compare trials from the 80s to trials in like CREST-2. So NASCET, as I just said, in symptomatic patient clearly showed a benefit. So did another trial called ECST out of Europe. And they both showed it. Now, what is also important to know that they took this step forward and started assessing endarterectomy in asymptomatic patients. And ACAS and the VS study called VAT both also showed reduction of reduction of stroke-like events with carotid endarterectomy over medical therapy. Granted, they excluded all the high-risk anatomy, high-risk features, and also elderly patients above the 80 years age. So that led to the revolution of carotid interventions, stenting, and so on and so forth. So many registries and eventually trials comparing carotid stenting to carotid endarterectomy trials happen. I'm not going to go into the details in the interest of time today. But then the question comes up, what about CREST-2 trial, the hot topic trial today? Well, remember, it is not comparison of stenting versus CA. Please remember that. This is not a conclusion of stenting versus CA, as Dr. Shishehbor had shown. So what did CREST show? The original CREST trial, it was a randomized trial of average risk all comers, basically symptomatic and asymptomatic patients, 2,500 patients. It was conducted between 2000 and 2008. And the primary endpoint include not only stroke and death, but also MI. And that actually showed that there was no major statistical difference in the primary endpoint between stenting and endarterectomy. One thing I do want to focus on today is there was, however, some subtle differences, especially minor strokes. Minor strokes were higher in the carotid stenting group compared to endarterectomy. And the question is, why in the world was that happening? Well, when you dig deeper into the CREST data, you found that most of the minor strokes were happening in patients who did not receive embolic protection device, which was not standard at the beginning of the CREST trial. So that leads to my question that has been asked for me to address. When to recommend CEA? These are some of the ones I recommend. Number one, because of what I just showed you guys, inability to use distal filter. That's a big no-no. I always stop after an angiogram, talk to the patient, assess the risk, maybe get the vascular surgeon involved. Because if you are not able to deploy a distal filter and provide that protection, as you have shown in the CREST data, your stroke risk is significantly higher, almost 3 times higher compared to using an EPD or distal filter. Elderly patients above 80 remains a debate. They were excluded in the original surgical trials, but I think since then there have been subsequently data which shows that maybe there is a better outcome in elderly compared to with CA compared to stents. Recent stroke is a high risk for carotid stent, but obviously common things like inability to take DAPT. You cannot do that on those patients. Inability to tolerate severe hypotension. I actually had a patient a few years ago with critical AS, was referred for TAVR. I ended up doing a carotid stent, and the patient developed severe hypotension, was on high dopamine and things like that overnight, and he decided to get out of his bed, collapsed, and had a very bad outcome. So I have learned my lesson that if somebody cannot tolerate severe persistent hypotension, be very, very careful on those patients. Advanced CKD, some patients have nitinol allergy, but obviously hostile percutaneous access. If so, these are vascular patients. A lot of them have occluded bilateral femorals, iliacs, abdominal aortas. I had, one patient even had occluded brachials and radials. So those are a lot of issues. But there are certain anatomical challenging subsets which you all must be aware of. Dr. Aronow talked about arches. So type 3 arch, be careful. Bovine arch, be careful. Everything becomes double, triple difficult when you have this. Tortuosity. Severe distal tortuosity is worse than proximal tortuosity. You can probably negate the proximal tortuosity, but severe distal tortuosity, as I've shown you here, may hinder the advancement of EPD, balloon, or stent, and that can become a massive problem. Calcification, which is circumferential and severe, they are very difficult to treat with stents. And thrombotic lesions, they are high risk of carotid stenting because of embolization. And what about the string sign? As one of the cases I showed you, these are subcaudal occlusions. There's a trickle of antegrade blood flow is detected, but distal embolization or vessel occlusion may occur during passage of an embolic protection device through a near occlusive lesion. So be extremely careful in taking on these challenging cases. But things have happened. CREST, CREST2, but also recently, Medicare. For the longest time, for all of us who've been involved in carotid stenting, we had to have institutional credentialing, patient allowance, insurance issues, because it was only allowed carotid stenting for high-risk patients. However, on October 11, 2023, CMS expanded. So now CAS with embolic protection, again, that's the keyword, in all patients with more than 50% asymptomatic asymptomatic more than 70% carotid stenosis, regardless of their operative risk status, has now been approved. And you can see that there is a steady growth in all comers, not only just symptomatic, but also asymptomatic patients who are getting carotid stents. So the question then comes up, will CREST2 change the mode of revascularization? I'll give you my 2 cents on it. Maybe, but I really, really doubt it, because there's a huge referral bias. Around the country, there are not that many interventional cardiologists who carotid do stents. There are not even that many vascular surgeons who are on board yet with TCAR. So on and so forth. So vast of the majority of the country is exposed to referral to vascular surgery the minute they see carotid stenosis. And vascular surgeons, especially the old timers, are better trained and they are very, very good at doing carotid endarterectomy. So the availability of your specialty also determines what kind of mode of revascularization your patient is going to get. What about outside US? Outside US, stents are expensive. So carotid end artery is one of the cheapest of all the modalities. So that is going to remain a very strong presence in OUS. And we still do not understand why in CREST-2 trial, CA was not better than medical therapy, even if prior trials showed benefit. And then the question is, A, if it's better than B, which means stenting is better than medical therapy, and B is equal to C, which basically means medical therapy. Does that mean A is better than C? Is stenting better than surgery? Absolutely not. That will be correct inference of something of a CREST-2 trial because it's a completely two trial done under one setting sponsored by NIH. CREST-2 does not give a definitive answer on method of revascularization. And also, think about it. It did not include TCAR, one of the biggest revolution which is happening in our field, because TCAR, as our surgical colleagues will tell you, now is becoming increasingly done because in all high-risk patients, it actually has shown on the VQI data that is probably has better outcomes compared to carotid stent or CA. And standard risk patients, it is definitely as good as CA, but maybe even definitely better than carotid artery stenting. So TCAR is growing, and you can see that this slide ends in 2022. These are the annual volumes of carotid revascularization in the United States from 2006 to 2022, according to revascularization type. And you can see there is a shrinking pool of CEA. There's a replacement in carotid stents, but also TCAR volume is steadily increasing. And I bet you in the last 3 years, it has grown even more. So what are the conclusions of what I'm trying to tell you today? There's a clear benefit of CA over medical management in symptomatic patients. However, CREST-2, which is an asymptomatic patient trial, the results creates more doubt. Only direct comparison exists between CA and transfemoral carotid stenting. Carotid stents causes higher peripostural stroke rate. CA causes higher peripostural MI. Remember, in CREST-2, there was no inclusion of MI as a primary endpoint, versus in CREST, there was. So that's a very interesting nugget to remember. The long-term composite outcomes are similar between the TCAR, however, only has been studied in single-arm trials and large registry analysis. It has not been randomized. Trial has never happened. CREST-2 did not include TCAR, so that is something to keep in mind. But the perioperative risk stroke rate is higher for transfemoral stenting than TCAR. Perioperative MI, stroke death MI higher for CA compared to TCAR, and 1 year outcomes are similar between TCAR and carotid stents or TCAR versus CA. CREST-2 data will not change much, but expect more revascularization will be performed with better acceptance of femoral artery stenting. There are a lot of physicians who still believe that femoral, the minute there is a carotid stenosis, they got to send those patients to endarterectomy. And maybe with something like a CREST-2 data, there may be a kind of a resurgence in transfemoral stenting. But however, ultimately, market forces will decide the mode. So going back to my cases, I'll just give you guys the answers of what we did very quickly. So this was a patient, 81-year-old with right ICA stenosis, but severely calcified. Or what did I end up doing next? This is what we ended up doing. We took a 2.5 balloon, 3.5 NC balloons. We used our coronary techniques, and then eventually did not expand. So ended up doing a 4 of Wolverine. But if you look at carefully, even Wolverine is not fully expanded. All my carotid stents are done with intravascular ultrasound, and you can actually see here severely calcified, 360 degrees, nodular calcification, eruptive nodules, whatever you want to describe. This is the lesion. So I ended up using a shockwave balloon. Again, this is off-label. Forgive me for that. And then we were able to get fairly good expansion with some post-dilation in this case. So severely calcified, I was able to tackle that. What about this patient? This is a very, very tough patient. This patient, actually, I remember doing him because he came to the hospital with a TIA. I did his diagnostic. I said, oh my God, my goodness, this looks like a string sign. I'm going to stop here. We'll get neurology involved, vascular surgery involved. He gets CERT activated the next morning, has another TI episode, resolves. And after discussion with all the disciplinary approaches, we said, well, take him back to the cath lab. And this is what we ended up doing. We first and foremost put in a distal APD, embolic protection device. We started doing a POBA. I was hoping that nothing bad would happen. Luckily, At the end of the case, we were able to establish some flow, but there was still a lot of thrombus burden, give this patient a lot of heparin and antiplatelets. And he did okay, fortunately. And after 4 weeks, we brought him back. And you can see where my cursor is. You can see that there is still a residual thrombotic lesion, but the flow is so much better. And I did another run of thrombectomy, did not get much out, but then successfully stented it. And since then, he has done really well. He's now 1 year plus out. So these are some of the approaches. What about this one?
Thank you, Alpesh. If you don't mind, I will move on to Dr. Grimsley because we'll have to do it.
Yeah, this is just my last slide. Otherwise, I was just going to say this patient is going to go for surgery. And that's what I landed up doing. So thank you so much.
No, that's great. That's great. Thank you so much. I'm sure Brad Grimsley, who is one of the nation's highest volume TCAR operators, would have a different say on the cases you showed. And I am going to invite him because he's my dear colleague at Baylor Scott and White, and I don't think I've known a more proficient carotid operator than him in carotid surgeon. In my acquaintance at both the institutions I've worked so far. So, Brad, over to you. We are eager to be enlightened because you are going to provide a perspective that is becoming very, very quickly much more prevalent, like Alpesh has shown. So, please share your slide and screen. And thank you again for making time for today's webinar and discussion.
Yeah, I don't mean to be sharing. I apologize.
No worries.
Now it's good. Now it's good. Well, let me start by ask you a question. Let me start by asking you a question. Get you warmed up.
Okay.
I think that both of our colleagues here have shown a few nice cases of where we think that TCAR may be advantageous.
Right.
At the minimum. I mean, I think if you want to take a very conservative approach, some of these type 3 arches and some of the challenging anatomies like bovine and so on and so forth. How do you judge going for the TCAR approach? Is it something that you feel should be done in every patient, or is it based on some of the discussion we have had earlier with Dr. Aronow and Dr. Shah?
Well, typically the patients typically will come to the office and they'll request a TCAR because they've done research and whatnot, but I always go through and I talk about looking at the ultrasound. If they haven't had a CT, I'll get a CT scan and we'll go over the calcification of the lesion, that kind of thing. We basically talk about all 3 options, but typically people want a TCAR. I've done a lot of TCARs. I've had an extensive history with carotid endarterectomies up until about, I'd say 2010, where I had done close to, north of 600, and then started doing more transfemoral carotid stenting and had built up about 300 to 350 of those. And then I started in 2017, I think, doing TCAR, and I'm close to 600 now. But it really has, when we train the fellows to do the same things, and a lot of them are going out in the community and doing more TCARs than they're doing anything else. But typically I'll just present to the patients and they choose a TCAR versus a carotid endarterectomy. If they've had a carotid endarterectomy on one side, typically they don't want to go through that again. And if you ask the people who have had endarterectomies on one side and TCARs on the other, most of the time they will be, they'll say, why didn't you do the TCAR on the other side? So typically I'll leave it up to the patient, but most of them gravitate toward a TCAR because of the safety profile.
Mehdi, I want to ask one question.
Yeah.
Alpesh raised a good point. I think all 3 of our panelists can answer, and you too. Where in the CREST 2 trial, the lesion selection or the other criteria for selecting patients or lesions different slightly for CEA versus the stenting arms, which might apply that more selective patients and lesions got into the stenting arm versus a more broader group of patients got into the CEA arm, which could have attributed to the differences that we see in the trial, or that is not the case? Could you comment on that, each one of you, please, briefly? Go ahead, Alpesh.
Yeah, so actually that was very well looked into. I think there was obviously a concern that there may be a selection bias from the stent perspective. But if you look at the baseline data, the graphs, they have zero difference in their baseline, whether it's clinical features, whether it's diabetes, women, and obviously the arteries and the anatomy. But also, what was very impressive is the intensity of medical therapy was equal in both the arms, and almost 70% achieved medical therapy. So there was hardly any difference in the baseline characteristics. So that does not explain. I really believe that if you look at it, the stenting arm reduced the event rates by 75%, but even the carotid surgery arm and endarterectomy reduced by almost 55%. It was not that it was that worse. It just did not
Absolutely.
meet the statistical criteria.
True. Herb, you agree with that take?
Yeah,
And
I don't have much to add to that. I don't recall there being substantial differences in the inclusion-exclusion criteria for the two arms, unless others on the panel do. And there were fairly similar baseline characteristics. Obviously, some of the lesion anatomy was easier to characterize because of the invasive angiography in the stent arm, but I don't know that you could explain away any of the findings based on those unless others know something I don't.
Mehdi, over to you.
Herb, I was going to ask you, you're too kind. Actually, I was Herb's resident when we were at Cleveland Clinic, so he's giving me a lot of credit. And he gave me one of my first research projects. We actually were looking at the association between inflammation and transcranial Doppler signals in patients with carotid disease. And so anyway, but I mentioned it first to thank you for the opportunities you gave me. But more importantly, as you said in your presentation and in your discussion, we did a lot of carotids in those days. And in your experience, what do you think is the appropriate number of carotids for someone to feel like, I think I've seen enough of these lesions. I've done enough of these arches. I think I can really tackle, these kind of procedures with comfort. And then parallel to that, also how frequently, should you be doing these? I see sometimes, people say, well, over 10 years, I've done 200. Well, it's very different than if you're doing it, once a week, twice a week, versus if you're doing it once a month, so any comments about that, given your experience and how things are now?
Yeah, no, I mean, those are tough questions. I think the first one's probably easier. I remember back in that era when we were doing a whole lot of intervention in a relatively short period of time. So it wasn't like skills were waning over time in between, we weren't getting rusty in between cases, right? And we were taking all kinds of anatomy. I mean, it was, I think, before we fully understood patient and, selection based on anatomy. But in that setting, most of us who were training agreed that it took about 50 cases until we felt like we had seen most things and were comfortable with most things. Now, the problem, of course, as you know, is that when it comes to setting the bar, if we're going to set volume thresholds in competency documents, is that if you set it too high, then there's no access, right? Because there end up being very few operators who actually have that experience. And I remember when the first recommendations came out, and they were consensus across multiple professional societies, the bar was set at 25, half as primary operator. And we all thought that was too low at the time. We, meaning those of us who had trained in a high volume environment. But I don't think it would have been practical to set it much higher than that because then no one could have done it. And even though it was set at 25, there were a lot of things that happened in the space, as you know, whether it was lack of reimbursement for standard risk, and so on. Ultimately, what we saw over time was very low volumes in the carotid artery stent arena, such that there are very few operators today who have significant experience or who have significant, experience from a year-to-year standpoint. Maybe they've done hundreds, but they're doing 5 or 10 a year. And so I think one of the biggest challenges that faces us is if we believe these data and that transfemoral carotid artery stenting is a viable treatment option to reduce stroke and death in patients with asymptomatic disease, how do we train up a cadre of operators so that they're equipped to do so? And I don't know that I have the answers to that. Maybe I'll throw that back at you to see if you want the panel's input on that.
Yeah, I mean, I love to get the input of everyone, Subhash and Dr. Shah. Actually, maybe I turn it to Dr. Shah, but also maybe as part of that, I was going to ask Dr. Shah if he can also comment. He mentioned, TCAR and as potentially as another alternative and some registry data that have shown that maybe it has some superiority or some benefit. But we don't have any level 1 data, any randomized trial. And when you get trials like this come out and you get surprised, like I want to be honest with you, I thought the carotid stenting was over. I thought I think most of us did, to be honest. We said medical therapy is going to be with the statins and GLP-1s and all the other good stuff that was happening in our fields with blood pressure control, that I would have lost big time if this was a betting game. So, do you think it's acceptable to take registry data without a level 1 evidence to recommend the therapy? And also maybe you can comment also about experience given the complex cases you showed, Dr. Shah.
Well, thank you, Mehdi. But there are a lot of questions that you just asked. Let me just quickly to make a note on the ongoing carotid stent operator recommend guidelines. Think of if you do 10 a year, that's basically less than 1 a month. I don't think that should be acceptable. We allow it because there is paucity of it, but maybe just like surgeons sometimes do, we need to be more careful in how many numbers we give. I think we at my institution we do recommend 25 to get started, and right now 10 a year. That's pretty much the standard nowadays. I still think is very little too low. But going back to your point about TCAR, here we have Dr. Grimsley, who is a fantastic TCAR operator. But one of the problems with TCAR, and I remember doing a debate with my vascular surgeon, you guys know Alan Lumsden and all, and we have a YouTube video on that, but that was almost 5 years ago when TCAR was brand new. And I remember being very adamant about the lack of data. There is no randomized control trial even now, Roadster 1, Roadster 2, Roadster 3, whatever it is. Again, and then subsequently, a lot of VQI data has come along. And the problem with VQI data is they are self-reported. There is no independent neurological adjudication of stroke-like events. So there are massive problems with that. But the truth is in time and experience. And now we are 5-7 years out into the TCAR revolution. And I think it is done so well, so safely by operators like Dr. Grimsley. And I think it is here to stay. Now, it also depends on whom you ask. If you ask an interventional cardiologist like me who does 70 carotid stents a year, I'm going to say, well, I do this better than anybody else. I will keep on doing it. However, I'm also a little bit of sour grapes because I don't do TCARs. So I'm obviously going to be a biased carotid transfemoral carotid stent operator. And that's just when Dr. Aronow talked about how he evaluated his patient, I loved it. I think that conversation with your patient, well-informed patient interaction, multidisciplinary approach is key to make sure this field grows. And this field has to grow not just because of the revascularization technique, but to your point, how impressed we are with the CREST data about superiority over medical therapy. And to make one more point, the differential between medical therapy and carotid stent is not as big in CREST-2 versus the differential in medical therapy and CA group. Actually, it just so happened that the medical therapy group had lesser events in the CA group, and hence it was not able to meet the statistical criteria.
That's it.
Be very careful.
That's
in how
a great point, actually.
Analysis.
It's a great point.
I think carotid endarterectomy is not bad. What my take-home message from CREST-2 is, yay, carotid stenting is not bad. That's the way I look at it.
Mehdi, I want to, Brad could not show his handiwork, which I have seen with and equally and greatly impressed. We're going to invite him back and he's going to sit in my living room and open my screen and share his slides. But having said that, we have a very diverse audience, Brad, joining the webinar. So everyone does not actually understand the way many of us do what TCAR is in a sense that why is this approach even was developed when you could deploy a stent from the groin? Why would someone need to cut into the carotid artery to deploy a stent? And can you very briefly in the maybe the final point for tonight explain to us and to the audience what does this entails and why was it even conceived?
Yeah. Well, I think some of the carotids that we looked at had a lot of tortuosity just distal to the bifurcation. There were some very difficult stenting cases, and you guys did a fantastic job of demonstrating that, the calcified lesions, that kind of thing. But ultimately, it's the arch problems, and also carotid, the distal to the bifurcation, the tortuosity distal to the bifurcation, and being able to get the filter in place, because you have to have some type of protection, obviously. So the reversal of flow was created. And when you cross clamp the common carotid artery and develop a reversal of flow for protection, you can, and I had some slides to show how when you do have tortuosity distal to the bifurcation, how you don't necessarily, it would be very difficult to get the filter in position in those cases. And how easy it is for a TCAR. You don't have to have the wire, or if you have the wire up and you pull the wire back just distal to the lesion, you can deploy the stent on reversal. So it has a lot of advantages that way. And we've known for a long time about carotid endarterectomy being a very good procedure for all carotid lesions for the most part. And then it just has some of the basic surgical techniques of cross-clamping the carotid. People tend to tolerate that real well, and then getting the reversal for protection. That, in addition to the arch problems that we run into with type 2 and type 3 arches with transfemoral carotid stenting, I think those were the main reasons why it was developed. So the good news is, and I think several of the guys have commented on, is that stents, and I've seen this over my course, some of the older surgeons, I think there's been some reference that those guys are really into carotid endarterectomy. They don't believe in stents, period. And even in my group, they feel that way. But they've sent me patients that they've done carotid endarterectomies on, and here we got recurrent stenoses, and that happens quite often, actually. And if you start comparing the carotid stents compared to long-term carotid endarterectomies, the data is exactly, these stents are here to stay. When you put a stent in and deploy it correctly, the patency rates are excellent long-term. So, and I think the CREST 2, that was very encouraging, that stents are here to stay, whether they're put in transfemoral or via TCAR. So that was very encouraging.
So the next carotid study should be TCAR against other approaches or medical therapy compared to TCAR. I don't think we will answer that question tonight.
No.
Over to you for some final thoughts on this, because this is a provocative question that I just want you to go to sleep with, because it'll be not easy to answer it right away.
Well, I think the medical therapy, obviously medical therapy is excellent these days, but I think the CREST 2 data, it shows that you add a stent to that and you got even better results, down the road, especially on out to, 3 and 4 years, as we showed earlier. So I'm very encouraged that, it really depends on which person you show up to. You show up to Dr. Shah and you've got a problem, put yourself in his hands. He does a great job. Yeah. Same thing with the other guys, Herbert. But for me, I talk to them. I feel more comfortable doing a TCAR than I do a transfemoral. Although if somebody's had radiation, they've got a stoma, they've got some reason that you don't want to cut down on the base of the neck, do a transfemoral carotid stent. They're excellent. And so anyway, yeah, great discussion.
Mehdi, over to you now.
No, I think that, it was a great discussion. I learned so much, so I want to just once again thank our panelists, Herb, thank you so much, Alpesh and Brad, really appreciate you guys this late in the evening, giving us your time, and, just grateful that, we have the opportunity to discuss. And as we always say, there's no one tool that can treat everyone. And thank God that we do have these different approaches, in atherectomy, TCAR, transfemoral carotid stenting, and medical therapy, available to us. And it honestly gives us our job back. Gives us it reaffirms that we need physicians that are sophisticated, and as goes back to Herb's point about shared decision making. So thank you so much. Have a wonderful evening, and I appreciate your teaching and the education that you have given us and our audience tonight. Thank you so much.